Hello, welcome to the third of our series of updated opioid use disorder trainings. Today we are presenting Understanding Buprenorphine using Uses, Benefits, and Considerations. And we have Dr. Jason Fields with us here today to present that. Dr. Fields, you can take it away.
All right. Hello, everyone. Hey, it's my honor to do this presentation on behalf of FATA today. I am an addiction medicine physician, American Board of Preventative Medicine certified provider, working for a large multi-specialty group, and I work for their behavioral health division. And I've been working with them for about 7 years on the front line treating addictions, and utilize buprenorphine every day in my practice. And it's a pleasure to talk to you about this topic, buprenorphine uses, benefits, and considerations. Here is my information. I do not have any disclosures to give today. And the learning objectives for this presentation: first, to understand what is buprenorphine and how does it fit into the broader framework for medication-assisted therapies or treatment. Buprenorphine is the medication, and the reason it's called medication-assisted therapies is that buprenorphine has efficacy, which I'll be talking extensively about, in helping folks with opioid use disorder get into remission from active substance use. To learn how buprenorphine works as a partial opioid agonist, keyword partial opioid agonist, with a long half-life. That's why it works so well. And its effects on the brain's opioid receptors. And I'm going to discuss some common protocols and suggestions for initiating buprenorphine in daily practice in different settings, outpatient, hospital, etc. Adjusting the buprenorphine to efficacy and maintaining therapy once you have someone induced onto buprenorphine products. To explore the policies and regulations surrounding buprenorphine prescribing, including the role of waivered providers. And good news, very good news, you no longer have to be waivered. I'll discuss that. Have a special waiver on your DEA to prescribe Schedule 3 buprenorphine products. So that's good news. And to recognize the approved use of buprenorphine and various formulations, of which we have quite a few choices now. For many years, we only had the sublingual forms of the buprenorphine to use, transmucosal, if you will. And now we have long-acting injectables, which is very exciting and has helped broaden our treatment options. So buprenorphine is a medication used to treat opioid use disorder, as well as acute and chronic pain. The majority of this presentation will focus on its efficacy for treating opioid use disorder, but it is also effective for both acute and chronic pain syndromes. So how is it used? It is used for those folks in the throes of active opioid addiction. Once initiated onto buprenorphine and dose adjusted to an efficacious dose, it reduces cravings for opioids and interrupts the withdrawal process, which many individuals on short-acting opioids these days, unfortunately, it's fentanyl out on the streets primarily, as well as continued prescription opioids, but misused prescription opioids. But it interrupts the withdrawal syndrome, which many individuals have so much difficulty getting through. And it doesn't cause euphoria when dosed properly, or shouldn't. And it has minimal side effects, really. So it's very effective for helping interrupt active opioid use disorder and prevent relapse. And frankly, it's used as a substitute, even though it is an opioid product, it is substituted for the opioid of abuse that is being abused. So it is not one drug for another. This is a medication, even though it acts as an opioid, to stop the abused opioid. and as mentioned, is part of a comprehensive treatment program as we get best outcomes with medication-assisted therapies when it's combined with case management, addressing comorbidities like mental health disorders, etc. What does success look like on buprenorphine? So research shows that a combination of medications like buprenorphine and therapy, so take-home point of the talk, this is medication-assisted therapies, can successfully treat opioid use disorder. What treatment does is reduces overall risk of overdose, which is still an epidemic. We have seen some promising data come out nationwide for the curve, which was, especially during the pandemic with COVID, exponentially increasing overdose deaths in the United States. It has flattened and started to take a downward turn. Mind you, there are still way too many overdose deaths, and it is still an epidemic, overdose from opioid use disorder and other substances, but it reduces the risk. And I would like to say that access to buprenorphine treatments and other medication-assisted therapies is causing this downward turn in national data in overdoses. It increases retention in treatment and recovery services. So when people engage outpatient level of care, residential level of care, when they go to detox and they come out of detox, if they are successfully induced onto buprenorphine, it helps keep them in therapy because it's not just the medication, it's treating comorbidities like medical conditions, it's offering psychosocial support and therapy for trauma, for example, and other cognitive behavioral therapies that are an important part of it. It's urine drug screening. It's working with case manager. It's helping folks find adequate housing. So it helps them participate and stay in a comprehensive treatment program. It improves daily functions. So individuals induced onto buprenorphine out of active opioid use disorder can start to go back to work, can look for work, can work on broken relationships and negative outcomes of active addiction, including indigency, for example. They can treat their comorbid medical conditions if they're diabetic, for example, or they can also treat their co-occurring mental health conditions, which is not done when people are in active addiction. And it reduces infectious disease risk as well. Hepatitis C, HIV, and other diseases that are increased with active IV drug use, which occurs in some of our population with opioid use disorder. By interrupting that and stopping that, it reduces the risk for transmission of these diseases. It also, if they do have hepatitis C, for example, which should be a routine part of screening for new patients coming into a buprenorphine program, if they do have hepatitis C, they can treat it. All right. And what you can work on for folks that are in treatment is patient-centered goals. One thing I like to do when a patient comes in and I'm initiating them on buprenorphine and they're getting started on a comprehensive program is I like to say, in your sobriety, what are your goals for yourself? And that's something you need to ask again. Often the first encounter, they don't feel good, they're in withdrawal, they are just trying to look for a solution. So especially as you follow up closely and frequently with these folks, you want to focus on what are your goals? It keeps the motivation up. So buprenorphine works as a partial agonist, partially stimulates the mu opioid receptor. And that is its primary mechanism to what we talked about, interrupt cravings and withdrawal. It binds to opioid receptors in the brain, okay, and of which there are plentiful. And by doing so, interrupts cravings and withdrawal symptoms. And when people are induced onto buprenorphine, buprenorphine has a very high affinity for the mu opioid receptor. And as a result, If they use other drugs of abuse while on buprenorphine, it decreases overdose risk because even fentanyl, Dilaudid, oxycodone, commonly abused street opioids, they can't get to the mu opioid receptor if buprenorphine is sitting on it because it has a higher affinity. So that's another take-home point. Risk increases for bad outcomes with comorbidities of other substance use, especially benzodiazepines, alcohol, gabapentin, which is controlled in some states, and also if they have underlying severe lung disease, they have severe liver impairment, and if they're opioid naive patients, okay? So, meaning naive to medication-assisted therapies. So, by getting on buprenorphine, it's not a contraindication when people have ongoing use of benzos and alcohol, stimulants, other drugs that have synergy in sedation. You still should induce them onto buprenorphine and work on getting them to curtail their use of these other substances. This is called harm reduction, okay? But getting on buprenorphine increases the risk with ongoing, say, heavy Xanax use, heavy alcoholism for bad outcomes. Also, a lot of street drugs, when people are intending to use, say, cocaine or methamphetamine, is contaminated, unfortunately, with fentanyl. So if they have, say, both an opioid use disorder and a stimulant use disorder, if they have ongoing stimulant use, you still should prescribe the buprenorphine, work on getting them to stop the stimulant use because of cross-contaminants and exposures. So the medication lowers the potential for misuse, okay, of other drugs as well. Here's a schematic that shows you exactly what's going on at the mu-opioid receptor. On the far left, you can see that this opioid receptor it is exposed, it is available to bind. And you have both buprenorphine in the blood, in your plasma, in your blood, as well as an opioid. Say that is fentanyl, say that is Dilaudid. Okay, if the opioid user continues to consume opioids, this schematic, the next one over, where you see the opioid, the full agonist attached to the mu-opioid receptor, what happens is that you get the phenomenon of tolerance occurs. They have to use more and more of this opioid, let's say it's fentanyl, to get the effect. They get desensitized to it. And eventually the individual can't get high, and they're only using opioids continuously to avoid withdrawal syndromes and be sick. So the next schematic over shows that if buprenorphine is on board, it has a higher affinity for the mu-opioid receptor than does fentanyl or Dilaudid, the other green molecules that you see there, the other opioids. And so they are displaced, and the partial agonist buprenorphine sits on the opioid receptor and partially stimulates that opioid receptor. And as buprenorphine dissipates, it prevents withdrawal and continues to block other opioids. So say you keep a therapeutic dose of buprenorphine on board, it is preventing any opioid from getting to that opioid receptor. So as I mentioned before, buprenorphine can be used in both pain management and addiction treatment. In pain management, it has efficacy because it partially stimulates the opioid receptor. It doesn't fully stimulate, but when opioid receptors are stimulated, it gives the effect of analgesia, pain relief. What's unique about buprenorphine, and there will be a schematic of this coming up, that as you increase the dose of buprenorphine, say to 16 milligrams, 24 milligrams, and certainly by 32 milligrams, all the mu-opioid receptors are occupied, And despite going up on the dose, you have a flattening of the dose response curve. That's called partial agonism. Okay. So there's a ceiling effect on the potential side effects, including respiratory depression for buprenorphine and other opioid effects. Even though you keep going up on the dose to make sure that all the mu-opioid receptors are occupied, you're not getting more effect from the drug. This is in contrast to, say, a full mu-opioid agonist like methadone, also used for opioid use disorder, or from street opioids like fentanyl, Dilaudid, what have you, oxycodone. The more that you take, the higher the dose response curve goes, the more effect you have. So it helps with pain management by sitting on that opioid receptor, stimulating it, has a long duration of action, slowly dissociates from the mu-opioid receptor, has a very long so-called half-life, much lower abuse potential than full agonists, and there are available and often used when it's used for pain, transdermal and buccal formulations of the buprenorphine. In addiction treatment, the same properties, the fact that it has a long half-life, sits on the opiate receptor, and prevents other opioids with lower affinity for the opioid receptor from binding to the opioid receptor. That's why it works for addiction. People in the throes of opioid use disorder, once they're induced onto the buprenorphine, can breathe a sigh of relief. It squashes cravings, and you don't have a withdrawal syndrome that is super difficult to get through. Let's talk about that. The withdrawal syndrome from opioid use disorder is a big reason why detox alone doesn't work, and why these medications are the gold standard. Buprenorphine is one of the gold standard medications, along with the full mu-opioid agonist methadone, along with the antagonist Vivitrol. When these medicines are added to someone who has been to detox, they are much more likely to avoid relapse and going back to active opioid use disorder. It is night and day as far as outcomes in the first 6 months to a year for avoiding relapse if they get on one of these gold standard medications. So detox alone doesn't work because people can't get through the opioid withdrawal syndrome very well. Even after the acute opioid withdrawal syndrome, which can last up to 2 weeks and peaks at about 5 to 6 days after your last use, depending on whether you're on a long-acting or short-acting opiate, the post-acute withdrawal syndrome symptoms persist for a long time, months and months. And so many people can't get through that abstinent-based or without these medications. The ceiling effect is an effect for both pain management and addiction treatment. So we don't have to worry about people overdosing on the buprenorphine as readily as we would a full agonist. Less side effects, much more tolerable for the patients, and that high affinity is in play when it works for addiction treatment. And we're going to talk about the fact that it's best practice, unless they have a contraindication and an allergy, to have the combination product naloxone, which is an antagonist, in with the transmucosal buprenorphine product. The reason that's often used as a combination, buprenorphine and naloxone, is because it deters people from insufflating, snorting, or injecting the combination product, because they would be in immediate withdrawal if they did. So there's added years back to deter, to prevent diversion. And the naloxone is not bioavailable. So in the combination product, when taken properly, the naloxone is not absorbed transmucosally in just very minimal amounts, so that it's not doesn't have a therapeutic effect. So it's when taken properly, individuals do not get the naloxone; they only get the buprenorphine. So forms of buprenorphine. Happy to say there's many forms now. Subutex is just buprenorphine alone. Suboxone is the combination product I was talking about with buprenorphine and naloxone. Sublocade and Brixadi are products that are long-acting injectables. Sublocade can be administered monthly as well as Brixadi. However, you can adjust dosing depending on patient response. Sublocade actually can be given per the PI every 26 days at a minimum, and Brixadi can be given every 21 days at a minimum and can be adjusted if individuals don't have that therapeutic result that you want. Decreased cravings between injections and lack of withdrawal. Interestingly, also Sublocade, the first 2 doses are always 300 milligrams, and the second dose now can be given earlier than a month. It can be given within 8 days for folks that perceive withdrawal or cravings after the first Sublocade injection. So all of these products, again, less euphoria because of ceiling effect. You don't have to worry about breathing problems. Less risk of misuse or overdose because of ceiling effect, and because often the buprenorphine is combined with naloxone in the sublingual forms. And you have various forms which work, which is, it's nice to have choices depending on the individual and their needs. And it can be prescribed. What's wonderful now, without a waiver, it's been quite a few years now, you haven't had to have a waiver to prescribe these products. You just have to have a DEA, like any other controlled medication, which is wonderful. So I've already mentioned a lot of these issues. This is examples of the combination product sublingual that we have. So Suboxone, buprenorphine, and naloxone. Zubsolv also is a buprenorphine and a naloxone combination. And Zubsolv, instead of going under the tongue, goes, for example, inside the cheek, buccal, transmucosal. But again, helps reduce misuse or diversion. Naloxone is the abuse deterrent, as we've talked about. Comes in tablets or films. Daily dosing is required for the sublingual forms. And most adults are on 8 to 24 milligrams a day. There's some anecdotal evidence that going up to 32 milligrams a day benefits some individuals. And all of these products can be, again, dispensed by anyone with a DEA license. No waiver required. Side effects. Doc, what are going to be the side effects of this medication? Well, I'm happy to say that buprenorphine is very well tolerated and rarely not tolerated to the point that some of the side effects make people want to stop the medication. It's unusual. So for all of these more common side effects, they're not really that common in clinical practice. I often don't have to deal with these. I would say of all of these, back pain, chills, cough, constipation, difficulty having bowel movement, hoarseness, painful or difficult urination, runny nose, sneezing, stuffy nose, trouble sleeping. Usually the ones we have to work with most, the side effects, and keep people on the medication, which usually almost always we can do, is constipation can be an issue, as well as the urinary hesitancy. People perceive difficult starting a urine stream, maintaining it. So these are usually self-limited, the urination especially. Also, I do have sometimes people get some peripheral edema, lower leg dependent edema. Again, usually self-limited. You can give them a diuretic if it's significant, and once they stay on the medication, it usually subsides, in my experience. But all medicines have side effects. Happy to report that with buprenorphine, they tend to be minimal, and I wanted to point out what we have to deal with the most. Usually an adjustment of diet and not putting people on a X-Lax or just putting them on a stool softener and not a motility agent is best. because they can be dependent on the motility agents. And drinking lots of water and adjusting diet usually works for the constipation. So let's talk about some patient considerations and give some examples of how we would get patients onto the medication. So people with opioid use history and risk of precipitated withdrawal. When you start these medications, precipitated withdrawal is something that we have to talk about and understand as providers. Always you do a careful history and physical for people with opioid use disorder. And you want to know their using patterns, what drug they use the most, what opioid they use the most, if they use more than one. If they're only using fentanyl, for example, when was their last use? Always important to know. And have they had complicated withdrawal before? And have they been induced onto buprenorphine before? If they have been induced onto buprenorphine before, if they have experience with this medication, the patient will often tell you what works best for them to get them back on the medicine. That's wonderful. So I just listen to them because they've been through it and they know. And if they had a good experience or if they had a bad experience, we can curtail this induction to their experience in the past. If they're naive, you definitely want to know, when their last use was. I want to talk about ways of induction. There's a micro-induction method, or the so-called Bernese method, and there's a macro-induction I'm going to talk more about. Traditionally, up until, let's say, about 3, maybe 4 years ago, micro-induction was used mostly, all right, or low dose for inducing. And I remember, 10 years ago, inducing people onto buprenorphine. Most often what I did was want to wait until they were in moderate to severe withdrawal. We still do that. And then start them on a very low dose, maybe, in clinical practice, you want to go as low as you can, maybe 2 milligrams at the time. After it's been about 12 hours, they have moderate to severe withdrawal, and start them off on small amounts at the time, every hour or two, increasing in small increments up to a therapeutic dose. All right, so that's low dose induction. There's also, or micro induction methods if you can get even smaller increments than 2 milligrams. So the Bernese method came about because some people do not tolerate the low dose induction. And with the Bernese method, it's hard to wrap your head around, but they continue to use the full agonist. So whether that's fentanyl or whether that's Dilaudid or oxycodone off the street, heroin in some instances. We're not seeing a lot of heroin these days, especially not in Florida. But whatever their full agonist is, they continue to use it as they start very small increments of buprenorphine, maybe down to 1 milligram if you can do that. Cut a 2 milligram film in half, for example, or 2 milligram Subutex in half, for example, break it in half. But you want to start low, and every day you give them a formula for slowly increasing while they continue to use their full agonist. When they get to about 8 milligrams of buprenorphine, you want them to stop the full agonist, and it makes it easier for some patients. This is a so-called Bernese method. I've had successes with this a handful of times. But what in recent years, about 3 or 4 years ago, what came into more vogue and is actually, in my clinical experience, more efficacious and works better is macro induction. And so that is something that any clinician that is starting with buprenorphine or has experience with the so-called low dose method, macro induction is, even though it seems like it may cause precipitated withdrawal worse, it actually gets folks through that risk of precipitated withdrawal much faster. And with this, as I'll detail in some upcoming slides, macroinduction is where you go ahead and when they're ready, it's been about 12 hours or more, their clinical opioid withdrawal score is high, they have moderate to severe opioid withdrawal syndrome, then you can start macroinduction. And you start with 8 milligrams or even up to 16 by some algorithms, and you give them another 8 milligrams every 1 to 2 hours, up to 32 milligrams on the first day. Then whatever they needed to get comfortable, feel like they could sleep, relief of craving withdrawal symptoms, you split the first day's dose, the induction dose, the total dose, say it was 24 milligrams. Next day, they start with 24 milligrams all at once in the morning, or split up to 3 times a day. So there's some examples. So you can tailor what works best to your patient, but you always have to educate and make the patient understand precipitated withdrawal is possible. Maybe they have experience with it. If they've used some Suboxone off the street when they couldn't find their drug, maybe they know about precipitated withdrawal. But you want to educate and you want to make the patient comfortable to let them know that we can tailor the induction to minimize this phenomenon. Why does precipitated withdrawal occur? Well, as I mentioned, buprenorphine has a very high affinity for the mu-opioid receptor, very high, much higher than heroin, methadone, fentanyl, and oxycodone, Dilaudid. So whatever their drug of abuse is, their opiate of abuse, higher affinity. So therefore, the higher affinity buprenorphine displaces, if you will, or takes the spot of the full opioid agonist of abuse readily. And when it does, it only partially stimulates that, right? Buprenorphine is a partial agonist. So they go from full opioid agonist to partial agonist. So you have some opioid receptors when you're starting off the buprenorphine. Until you get to a therapeutic dose, you have partial agonism where there was full agonism for a little while, until you get all the opioid receptors occupied, which is the idea of macrodosing. You want to get all those opioid receptors occupied as quickly as possible. And that's why macrodosing, instead of drawing out the precipitated withdrawal discomfort, it quickly moves through it. And that's why I have had better experience with macro induction. There's the schematic showing the ceiling effect of partial agonist buprenorphine versus a full agonist. As I mentioned before, the dose response curve keeps going linear with the full agonist as opposed to the partial agonist. If you are using the medications naltrexone and naloxone, they are antagonists. And to avoid any withdrawal, you have to be completely through the opioid withdrawal syndrome. An advantage of buprenorphine is that patients can start their medication-assisted therapy quicker right after stopping their drug, within 12 to 24 hours. But you have to be through the opioid withdrawal syndrome completely to start naltrexone, which can be difficult to achieve at times. So again, induction with buprenorphine should ideally begin when the patient shows moderate withdrawal. And there's a clinical opioid withdrawal score that is standardized. I'm going to show you an example of it and how scoring occurs. But when you're over 8 to 12 on the score, that is when you can start thinking about inducing, along with some symptoms of opioid withdrawal, like sweating, restlessness, yawning, GI upset, tremor, anxiety. Anxiety is a big part of the opioid withdrawal syndrome. Here's the clinical opioid withdrawal scale, so we can objectify the patient sitting in front of us about their readiness for induction. As you can see, looking through this, there's a resting pulse rate, there's sweating, there's restlessness, pupil size, bone or joint aches, runny nose or tearing, GI upset, tremor, yawning, anxiety, irritability, and goose flesh skin, goosebumps are the categories. And then there's a scoring for whatever you see. And it helps with regular use. You can kind of quickly come up with an idea about where they are, whether they're in mild, 5 to 12, moderate, 13 to 24, moderately severe, 25 to 36 score, or severe withdrawal, more than 36. For the purposes of our clinical experience, or saying you want to get them to 8 to 12, which is high mild or at least moderate. Concurrent substance use, it's rare that the individual comes in just abusing opioids. And part of the comprehensive history and physical is, what are your other substances of abuse? Of course, you always want to have a urine drug screen and an evaluation for substance use so that you can, in real time, what's there and ask about it. But just like you are diagnosing opioid use disorder, you want to diagnose any using DSM-5 criteria, which I'm going to show you an example of for opiate use disorder. You want to diagnose any alcohol, benzos, stimulants, cocaine, methamphetamine, kratom comes into play, other drugs of abuse that are psychoactive. Okay, you want to know what they're using, and you need to address these too. For a person that has alcohol use disorder with a history of complicated alcohol withdrawal, as well as opioid use disorder, you're deciding whether you want to give this patient an opportunity for an outpatient detox versus an inpatient detox recommendation. So with complicated benzo or alcohol withdrawal and concomitant use with opioid use disorder, this individual might be best served in an inpatient setting. Okay. Now, there's always what the patient is willing to do, and you have to take that into account, and we're harm reduction. But this helps you do some clinical decision-making about the best setting for the induction on buprenorphine products. So medications to use with caution. So if there are medications that they are either prescribed or using actively when they're doing their induction with buprenorphine, caution with benzodiazepines and gabapentins, okay, which can have synergistic sedating effects, for example. So maybe not ideal for the patient with advanced lung disease, for example. So you want to use caution. And you also want to be aware if they're on certain medications that slow the metabolism in the liver of buprenorphine. These are your macrolide antibiotics, and certain antifungals are common offenders for this, competing with the metabolizing enzymes for the buprenorphine. In a comprehensive evaluation, you have to address the comorbidities. One of the reasons people are coming in to see you is because of negative consequences. And maybe their diabetes is out of control. Maybe they have been through infective endocarditis and they are looking for a solution for staying sober out of a hospitalization. But a thorough medical history, because health improves. When you get on medication-assisted therapies and you interrupt especially IV drug use and take away the threat, decrease the threat of overdose, you are helping people stop active addiction, let the forebrains wake up, quiet the limbic system where addiction lives. So as their executive functioning and their forebrains kind of wake up and get active again, out of active addiction, they can attend to their medical problems as well as their comorbidity for mental health. So bipolar individuals, people with anxiety disorders, people with trauma, individuals with schizoaffective disorders that need to be on medications, they often don't tend to their mental health needs, their comorbidities in the throes of active addiction. So thorough history, and you know what you want to treat either in your clinic or with the help of other providers, their primary care physician or their specialists. As far as labs go, there is a recommendation for an evaluation to obtain baseline liver function tests. If I take a history and there's questionable history of moderate to severe liver disease, patient's been jaundiced before, has maybe advanced hepatitis C, etc. Getting a baseline liver function is a good idea. especially if they have any signs or symptoms of advanced liver disease. It's important to do it. That's why it's important to do a comprehensive evaluation, physical and history. And in patients with advanced lung disease like COPD, sleep apnea, etc., you want to use caution. That's why, though, buprenorphine is one of the safer medications to use because of its sealing effect on respiratory depression. So, worried about this buprenorphine I'm prescribing, do I have to worry about them diverting? Well, if they do take more than prescribed, which is not uncommon, right? If they do run out early, if they do get buprenorphine off the streets to supplement, etc., that sealing effect on respiratory depression comes into play, and you can feel safer about trying to get them back to taking the medication as prescribed. So with patients that overtake, that divert, I work with them. I try to get them on the dose. I talk about alternative methods, say that they can't control how much they take for buprenorphine, and I can talk to them about the LAIs, the long-acting injectables, so that we take that having to handle it and try to avoid overusing. It's a wonderful option, for example. But you want to evaluate, but avoid, in people engaging MAT with buprenorphine, avoid punitive assumptions. You should always check, and in the state of Florida, it is law that before you prescribe a controlled substance, you need to check the PDMP. And we do. I do that. I see what controls have they received. Are there controls from outside providers I'm unaware of? Commonly, you find out that they're prescribed a lot of Xanax by their primary care physician, for example. But you always want to be checking the PDMP and helping the patient, right, with accountability. I see here where you've been getting these prescriptions for oxycodone. I see that you have some of these left. We're going to start you on this, but can you bring in the remaining oxycodone to be destroyed, for example? Consider an observed induction if you need to. In busy everyday clinics, a lot of reasons. I primarily work outpatient, and a lot of the reasons they're coming to see me is that they want to get back to their daily lives, and I'm busy, and sometimes I don't have time to sit with the patient for 3-4 hours for observed induction. But I have done it. I have done it, especially when the patient is very apprehensive and concerned. With education and support and close follow-up, you can do a lot of inductions outpatient. And I always give handwritten materials also to the induction. So I verbalize, narrate how this will go, but giving patients a guideline written down is very useful for them. And knowing that they have close follow-up and a number to call if they need to talk to you about how things are going. And what we're doing is harm reduction, folks. Harm reduction. So even if they continue to use their other substances, even if they're high risk with medical comorbidities, you got to look at the fact that, hey, this person had an overdose with fentanyl 2 months ago. They've returned to active use. They're here for help. We're going to do this. They're not willing to go into detox. I'm going to give them a try at an outpatient induction. So all these kind of things come into play, right? You have to adapt recommendations to real life and keep harm reduction in mind. Better to prescribe these medications if they're not abstinent from all other mood-altering substances, for example, even if they continue to use their marijuana, what have you, when you are helping prevent overdose from opioids. So considerations when choosing a treatment plan with buprenorphine. I've talked about formulations. Luckily, these days we have options. You can do the sublingual, you can do the monoproduct for people that have an allergy to the naloxone. And you have the long-acting injectables, which are much better for some people's lifestyles, especially when they have issues taking the Suboxone properly or with keeping follow-ups. Okay, psychosocial environment. You want to look at, and luckily, buprenorphine, you can address these issues. I'm fortunate to work in a clinic, an outpatient clinic that has case managers, that has psychiatrists to treat comorbid psychiatric issues, has access to higher levels of care like detox and residential level of care. We have outpatient level of care, but we have therapists to help them engage um, outpatient programming, extensive outpatient or intensive outpatient programming, where they have individual and group therapy as well as color code. So you can adjust the treatment plan to help improve this. Also, maybe they need to be in sober living for a little while. Maybe they have an unsafe home environment or a place they have a using family member and they just can't stay sober in their home environment. But instability should not be a reason to not start medication. Harm reduction, remember that, take home point, harm reduction. Get them started and work on these issues. Past treatment attempts is important. As I mentioned before, for patients that have been induced onto buprenorphine, they will often tell you what worked for them and what didn't work for them. And perhaps they are back and they realize, you know what, I asked to be weaned off at 6 months, but then 3 months later during a stressful time, I relapsed. So it doesn't matter how many past treatment attempts they've had. If they're coming back to get back on efficacious buprenorphine, the provider should oblige and get them on it. Okay? So, special populations, going to go through this kind of quickly. Pregnant women. Buprenorphine works for pregnant women with opioid use disorder just like it does for other populations. And ACOG, the American Academy of Obstetrics and Gynecology, recommends that buprenorphine, along with other medication-assisted therapies, is the standard of care for pregnant women with opioid use disorder. Prepartum, intrapartum, postpartum. They can be induced if they're active in their opioid use disorder and naive to buprenorphine. They can start that. If they're on buprenorphine and become pregnant, they should be continued on buprenorphine. And medication formulations can be adjusted. There is some suggestion that Subutex, the monoproduct, is safer than Suboxone. That is being challenged, I think, with some anecdotal evidence and some research evidence. But adjusting their medication and keeping them on the medication is important, and keep them engaged in treatment with buprenorphine is important. There are better maternal and infant outcomes for women with opioid use disorder on medication-assisted therapies. Adolescents. So buprenorphine has an FDA indication for 16 and 17-year-old adolescents. So, of course, 18 and up when they're adults, of course. But it is the primary FDA-approved medication for treating opioid use disorder in 16 and 17-year-old youth. And then both formulations of buprenorphine, sublingual films and tablets, are approved. Extended release forms are not approved yet for patients under 18. That's the Brixadi and the Sublocade. But treatment just in older adolescents, same for adults. Gets them out of active opioid use disorder, treats withdrawal cravings, and helps keep them in treatment retention, and improves family dynamics. Seniors, again, buprenorphine safe and effective for this population as well. Chronic pain is more prevalent in seniors, and buprenorphine, when dosed several times a day, 2 or 3 times a day, or especially in the long-acting injectables, can address both active opioid use disorder and assist with chronic pain, which is wonderful. Safer for seniors, buprenorphine as a medication because of the lack of respiratory depression, ceiling effect on respiratory depression, and no cardiovascular strain compared to methadone. Full opioid agonist. Okay. Now, methadone has worked for many people for many years out of federally regulated opioid treatment programs. So we're talking about buprenorphine as an alternative. But methadone is FDA approved and has saved a lot of lives. Causes fewer cognitive effects and less sedation. Buprenorphine, the extended release options improve compliance, as we've mentioned, the LAIs, and when administering to seniors that are on depressants, say like benzodiazepines, gabapentin, you want to be careful as they are more vulnerable to respiratory depression. So patient initiation, this is the DSM-5 criteria for opioid use disorder. And you can have mild, moderate, or severe opioid use disorder. They have an opioid use disorder if they've had 2 or more of these criteria in the past year. Okay, and then it goes on to moderate, up to 5, and then 6 or more severe opioid use disorder in the last year. Okay, note tolerance withdrawal is on there, and these 2 by themselves don't work. If you just have tolerance of withdrawal, you don't diagnose opioid use disorder, because someone without an opioid use disorder would have tolerance and withdrawal if they were taken off of their oxycodone that they are taking properly, for example. So those 2 can't stand alone to give the diagnosis. They need to be in combination with one of the prior criteria, like taking in larger amounts over time, neglecting daily activities, to continue to use despite dangerous situations, etc. So, initiation protocol in an ED, one of the many settings, buprenorphine can be initiated in the emergency department, can be initiated in a hospital setting, outpatient, multiple options. We even have a program going on where first responders can have buprenorphine and talk about this and initiate for the patient. They can dispense it. So you want to assess you want to make the diagnosis. To have a moderate, you have to have 4 criteria or more, opioid use disorder. Look for signs of withdrawal. It's suggested you initiate if they have 2 or greater objective signs. Some of those mentioned right there. And then the timing for starting. Withdrawal typically begins 24 to 36 hours after last usage, and start when withdrawal is clearly present. And if you use a clinical opioid withdrawal score, again, greater than or equal to 8. Precipitated withdrawal can be addressed. Patient can be educated on it. And again, with macrodosing, you may move through it quicker. The initiation process, you want to confirm withdrawal, patient readiness, initiate the sublingual dose. And if symptoms worsen, what you want to do is be aware of precipitated withdrawal, prepare the patient, and you actually continue to give more buprenorphine. You don't withdraw it. You don't sit back and wait. Is not a recommendation, but moving them quickly through precipitated withdrawal with the macrodosing examples I was given is recommended. Okay. So underdosing is a common mistake, if you will, or a common issue with not getting to a therapeutic dose quickly enough. Okay. In patients that had a rescue with naloxone, and they are currently on naloxone, and they've gone through their intense withdrawal that people go through when they are saved from an overdose, there is a window where you can initiate buprenorphine, and as the naloxone dissociates from the mu opiate receptor, the buprenorphine will take hold and sit on those opiate receptors. And so that is something that can be done in the ED as well. All right. And then from a discharge from the emergency department, they should leave with a prescription. If you've initiated them on it, you can give a prescription, which they can take to a pharmacy. You want to prescribe at least 16 milligrams and up to 32 milligrams for 7 to 10 days, giving them time to get to an outpatient provider for opioid use disorder. No X waiver is required, and there's a 3-day rule where medication can be dispensed, given in the emergency room for up to 3 days, so the patient could be dosed. They could come back for up to 3 days to get the medication. With ERs, this isn't always practical. This is kind of difficult to achieve, but the rule is there. If there is no lack of access to follow-up, this is occurring during a holiday weekend, for example, or there's just not patient access to a provider or ability to fill a prescription, this can be done. Where at the institution, like in the emergency room, you can give the patient 3 days of dosing on site. All right, so induction protocol, again, this is just kind of what we talked about. You want to assess the patient. You may do some baseline labs, especially if they have history of liver disease. You always, in women of childbearing age, you want to do a pregnancy test always. And just a full exam, get all the information after you make the diagnosis, and educate the patient on all the options, of which there are many that we've reviewed today, and motivate them. What do you want to do with your sobriety? What do you want to work on? And their comorbidities that may be causing them a lot of problems, or their life situations like chronic homelessness and unemployment and indigency, they get to work on that. Motivate the patient to come back, keep the follow-up, keep working on staying on an effective dose, right? We've kind of already gone over timing and withdrawal readiness for initiating buprenorphine, typically 12 to 24 hours after short-acting opiates. If they've been on a longer-acting opiate like methadone, it could be even longer, or with fentanyl, which is lipophilic, fat-loving, and slowly comes out of the system. So, but here's an example for initial dosing, starting with, let's say, 8 milligrams, reassessing every 1 to 2 hours, and giving another dose on day 1. And day 2 and beyond, you adjust based on symptoms with a typical maintenance of 8 to 16 milligrams. Okay? With fentanyl being the drug of choice for many people these days, you often need higher doses than 16 milligrams. It's just a reality. So many of these folks may be on 16 or 32 milligrams, for example. Okay. Again, if the patient feels worse, you keep dosing. Move them through that precipitated withdrawal. Education on the front end for this is very important. Okay. Telling the patient they should go home with naloxone. If they relapse to full opioid agonists like fentanyl, they want naloxone on hand in the household. They want to let loved ones or roommates know that it's there. Don't use alone. Tell individuals if you're going to use, do not use alone. Have someone around. And follow up. Keeping these patients engaged, keeping them on medicine, working through precipitated withdrawal issues. Close follow-up is important. Seeing the patient back, if possible, in 24 to 72 hours after initiation. Okay. I want to look here. This is adapted directly from a great resource that I'll share with you. And it talks about a light habit versus a heavy habit for opioid use disorder. If a patient has a light habit, that is using, say, oxycodone or just some street prescription opioids, misusing them or overtaking them if they're prescribed. And you want to consider that this patient may need to start with a lower dose. However, what is a lot more common clinically now is what's so-called heavy habit. They're using fentanyl or they're injecting heroin. And you want to think about a higher dose, even up to 16 milligrams. That's that macro dosing, right? 16 milligrams, 8 to 16, you start them on, and then every hour or two, you're giving them another 8 milligrams, up to 32 milligrams for the first day. Anybody that practices, addiction treatment, use these medications, use buprenorphine, have some barriers, okay? We're trying to improve the number of available prescribers, trying to train more physicians now that you don't need a waiver on the DEA, and education to the community by providers like myself that if you have a DEA, you can initiate this in any clinical setting, like whether it's the ER, hospital, etc. But increasing fellowships and in addiction medicine, and educating on the need for providers. Institutional policies, a lot of folks with this population, they don't want to or don't want to look into how do they get their urine drug screens. They simply just have to know that they can initiate these medications and then be familiar with who's in their area that can help these patients and maintain them. Behavioral health centers in the area, for example, or they can refer them to telehealth. Telehealth has increasingly become an option for patients that do not live close to a institution that does buprenorphine treatment, outpatient buprenorphine treatment. So we covered that in geographic, limited medication availability. This has become kind of, in my experience, an increasing issue. I have had Walgreens, I have had CVS tell me that they have a cap on the number of patients on controls. I think this is just a company decision about that, because, I've also had scripts not filled unless I put the diagnosis code on there, whereas I never had to do that before. So education of pharmacies and trying to overcome these so-called policies that aren't based on regulation. We need to work on that. Insurance is always an issue, copays. I see uninsured and insured patients in my clinic. Some providers can only deal with insurance. It depends on who they work for. But, affordability is a big issue. And I would like to see, that's political, right? We need to talk about, if we're going to continue to flatten the curve that we're seeing in overdose deaths from this epidemic, we're going to have better patient access and affordability for staying in treatment. So some of the barriers: stigma. It starts with the provider. Opioid use disorder is a disease. When it's viewed as a disease, it helps with all of these major sources of stigma in treating opioid use disorder. It's a brain disease that has effective medications, one of which is buprenorphine, to put people into remission from active substance use. Because active disease is manifested in behaviors viewed as negative socially, it generates a lot of stigma. So when you're treating the disease and not the person that leaves AMA continuously, neglected child rearing duties for whatever the disease, whatever the issues, the source of stigma, they are active in a disease process. Their frontal lobes are shut down. Their limbic system is in overdrive, so their cognitive and reasoning is severely diminished with this active disease. So training gaps need to be worked on. What language we use. We don't want to call someone that has the urine drug screen positive for fentanyl, say their urine's dirty, and talking with them. Okay? We can say positive for fentanyl, right? We don't have to stigmatize with that kind of language. And treatment culture. We're treating a disease. Okay. Source for community level stigma, I've touched on. Cultural and social norms, misinformation, one drug for another. We know after this talk that's clearly not the case. Peer and family pressure, or pressure from so-called 12-step programs, which are very accommodating. Alcoholics Anonymous has a policy where they allow for medications to treat behavioral health issues. And buprenorphine is a medication. But sometimes I have folks telling me that their sponsor said they're not sober. So just education of the patient that they are eligible for recovery is super important. Media representation, people in the throes of active addiction often do crimes, etc. But they're active in their disease. And institutionalization doesn't treat disease. So people can get out after years of being incarcerated, put in for sequelae of an active opioid use disorder, and go right back to using. You need to treat the disease. And so there's some just examples. So again, X waiver is no longer needed. So that regulatory consideration is off the table. It's wonderful. Telemedicine becoming is available. You can prescribe buprenorphine. You can do all of this under DEA and HHS regulations. Does permit telemedicine for initiation and prescribing, including audio-only options, which is nice. And I talked about the 3-day rule for providers that can dispense, not write a prescription, but dispense up to 3 days if there's lack of follow-up access. Okay. Safety considerations, you always want to see patients often and early, inquire about safe storage of medication, limit the medication supply, and see them back often. Use the buprenorphine naloxone combination products is always a good idea and is my standard unless they are allergic to naloxone. Counseling them on taking their medication as instructed, utilizing a treatment agreement regarding program policies and random urine drug screenings and pill counts. Treating comorbidities, seeing them back. Okay. So it's been my pleasure to talk about buprenorphine today. As you can see, I'm very enthusiastic and excited about this medication option, and it is now time for our testimonial.
Thank you, Dr. Fields, very much. We appreciate you taking your time today to present this presentation and share your expertise and knowledge. Now we have Stephen Zopinski with us, who has taken the medication, to give us a short testimony on his use and why buprenorphine helped him through his recovery process. Steve, it's your time to share.
Thank you, Diana. My name is Steve, and I'm a person in recovery, and I have experience with buprenorphine, or Suboxone is what it was called when I was introduced to it back in 2003. So in 2003, a little bit prior to that, I had begun using oxycodone, and it progressed to the point where I needed to have it every single day when I woke up. It was the first thing I thought about. It's comparable to today when I get my coffee when I wake up, just a lot more severe. So it's the first thing I woke up and thought about. It is the second thing that I thought about, and it continued like that throughout the day. So with the consequences of the actions that it had caused with me, I decided that with my parents' help at the time that I needed to get help, but I didn't know where to go. So I went to a facility in Tampa Bay, and this was I think it was a relatively new medication at this time. And I went to a 3 to 5 day detox where I was introduced to Suboxone. And the information to me as the patient at that time was pretty limited. They didn't have too much other than saying it's going to help you feel better. So what ultimately brought me there is I had to have it every day because my body would not function, and my mind would tell me that I couldn't do anything because my body wouldn't function because I was going through withdrawals so bad, so severely. So I was looking for the relief there, and Suboxone, it was extremely helpful in that regard. It relieved the symptoms that come with withdrawal, and it gave me moments of clarity. In the beginning, my mind was still a little bit foggy, and I still had a little bit of trouble concentrating. However, the mental stabilization that I was able to experience gave me the moments of clarity for the staff at that time, for the brief time that I was in this facility, to start talking to me about counseling and group therapy, There was other peers there that were on the same medication. So we kind of created this micro community and started talking about this medication and how it benefited us. When I left and got the referrals to continue outpatient treatment at the time, and I went to a doctor's office and got prescribed and put on buprenorphine to continue that treatment. I noticed that my family relationships improved. They were still skeptical, but I was able to hold a conversation with them. I was able to show up, which was amazing at that point because I was always in such fear that I was going to not have what I needed to show up with my family. And it really, really hindered my social relationships with them. And it allowed the clarity for me to start formulating a plan. And then in the community, there are community providers. They are commonly known as 12-step programs, and I've attended them for a while now. The first time I attended them was when I was on the medication, and that was a difficult process because there were some individuals that were pro medication use, and there were others that weren't. So it was difficult to find the ones that didn't make me feel bad about getting help. And currently, if you fast forward these today, we're much better at that. But the stigma is what it's known as, is highly, highly active and still around. So that is being addressed, and I'm thankful for that. So then when I continued my recovery after that, I was able to get more and more clarity, and the buprenorphine allowed that stability. Every single day I woke up, I went to work, I began to gain my self-confidence again. I realized probably a short time after I got out of the detox, probably 2 months, I would say 3 months, that I hadn't thought about going and getting the Oxycontin or oxycodone to use the illicit drugs. So at that point, I really felt a hope that I wasn't going to be chained to this illicit drug use for the rest of my life. Without that introduction and the stabilization for the physical withdrawals, I don't honestly believe that I would be here today. I don't believe that I would be where I'm at in life. I don't believe I would have the relationships that I have with family and friends, and just the joy has come back. I'm no longer under this dark cloud of misery. More importantly, I would say, is not only does it allow me the ability to learn continuously, but it also allows me to share the information now that I know and my experience with other peers that are within my cohort. So it's that value in and of itself is extremely powerful. We have the medical side of things, but I'm more active in the community. I still go to community-based support groups. I'm still involved. I still volunteer, and I have a family and I have a purpose today. And I'm appreciative of every experience that I have because it was so difficult to maintain just my life that I don't feel I would not have been here today. I would have passed from it. So I'm extremely grateful for the medication and what it's done and the avenues that it has introduced me to with the counseling, with the therapy, with the peer support, with the 12-step meetings, with the community involvement. I just am extremely grateful for all of that. Thank you.
Thanks, Stephen, for sharing your story. We greatly appreciate it that you did that today. For those that are viewing this recording, this presentation has been certified by the Medical Education Council of Pensacola for physicians, PAs, MPs, DOs to gain some CEUs, CMEs actually, for their participation today. So for those of you who have watched this recording, you can use this QR code to go into their website to share your experiences today and to gain that. Again, I'd like to thank Dr. Jason Fields and Stephen Zabisky for sharing his story today. And I hope that you all have learned from this presentation and are willing to share the information with those that you work with. Thank you and have a great day.